Hi, everybody. Peace out on all of you everywhere. This is Dr. Hossam Ziada, Assistant Professor of Ophthalmology at Azhar University, Cairo, Egypt, cataract, cornea, and refractive surgeon. First of all, I want to thank gratefully Dr. Brahmani for his kind invitation to this to share in this great event and a very prestigious webinar conducting the course about the manual osmosis and cataract surgery, which is advancing all the time, providing us the opportunity to do the hard cataract and the challenging case with more safety and at the same time with very good visual outcome for the patients. So my talk today is about conversion to the manual osmosis and cataract surgery techniques in the hard cataracts. In my opinion, this will save your patient's eye and at the same time save your coronaries. And I think all of us need to save the coronaries because every case will decrease, will take a moment, or will pick a moment from the age of your coronaries. Let's go. This is the great society, which is the International Society of the Manual Osmosis and Cataract Surgeon. I'm honored to be the president of the Egypt chapter of this great society, conducting the manual osmosis and cataract surgery courses in Egypt, here in my country. So we are supporting the Indo-Egyptian collaboration in these scientific issues. I will skip this video. And really, I'm pleased to show this lovely photo with Professor Amolio, Professor Brahmani, and Professor Goget on the day when we signed the contract of the launching of the Egyptian chapter of the great International Society of the Manual Osmosis and Cataract Surgery, with all happiness and honor to all of us here. So the manual osmosis and cataract surgery, which is meant with it the scleral tunnel, the sutureless scleral tunnel technique, it is a very crucial and very important step for every surgeon to know. The first step should be the extracapsular cataract surgery, in my opinion, and then the manual osmosis and cataract surgery, and also fecal emulsification. You have every cataract surgeon should be fully equipped and should be able to do all techniques for the different situation, and will choose, and the surgeon will choose the suitable technique for each patient. So the manual osmosis and cataract surgery techniques versus phaco will be more suitable, in my opinion, in the cataracta nigra, in the very old age with hard cataracts, especially with the bad cornea and the vulnerable endothelium, in patients with vulnerable endothelium and capsular bag as well. So I will show in this video one of the cases done by me using the technique of the manual osmosis and cataract surgery, and I used to do it in the all hard cataracts today. I'm doing the scleral tunnel. I'm placing it to 0.5 millimeter from the limbs to be sure that the astigmatism will be very less. It's harder approach, but with very good results after the surgery about the astigmatism. Then I'm doing the capsulexes without stain, then dilating the tunnel. And this nucleus is very big nucleus. very big one. So if I try to do it with phaco, I will use a lot of power, and I'm sure I will hurt and burn the corneal endothelium. It was obstructive labor, really, but it was divided during the delivery for 2 pieces. Then I removed all of it with a visco expression. Then now I'm preparing for the implantation of the PMMA IL in bag, rotation in bag through the bidrexis, then stromal hydration of both lips, and finally the lovely air bubble showing that the iris in place, there is no iris prolapse, and closure of the conjunctival periotomy with this coronary, with no stitches at all. And I think the eyes is in as well. Now, the same case, mostly the same case. I'm doing it with phaco, and I did the most all difficult cases with phaco. There is no problem for me, but there's no need for coronary insulting, for stressing yourself, and there's no for more ego. I had done. So what's after? So I'm doing very thoroughly and carefully, and I was calling during these cases. I was calling the endothelium all the time with the viscoelastic in every other step. So what's in the next morning or 2 days after surgery, as I'm showing here on the right side of this slide, the patients with manual small incision cataract, and the left side after phaco. You can see the difference here. The patient on the right side is very comfortable. The cornea is very crystal clear, and the air bubble is dancing. So the patient can open his eye very comfortably. On the other side, the patient felt some peripheral spasm because of the photophobia, and the very mild, it's actually very mild degree of corneal edema after surgery, I think, but still photophobic and feeling discomfort on exposure to the light. I was trying to help opening the lid on the left side. So the patient's eye will be much better. The surgery will take fewer time, and your coronaries, I think it will be healthier with that technique. Provided that, I have to be honest, provided that you have a skills for the manual small incision cataract surgery. If you are a skilled surgeon, it will be a great and wonderful procedure. If not skilled, it will be nightmares. I will skip this video again. I was showing during this video that if you plan from the start from the manual small incision cataract surgery in such cases, this case was male 100 years old with very hard cataract. I tried to do it with phaco to decrease the maneuver and the time for this very old patient, but unfortunately it was a bad decision because I was stuck with a subluxated lens, subluxated bag, and a very soft eye. So the cornea was not helpful all the time. So I converted to extracapsular cataract surgery through a corneal incision, which I dislike it. But if I planned from the start of the manual small incision, it would be better. It would be safer and easier technique. Here, I removed the lens from a small opening, a small incision. I tried to keep it smaller one to deliver the pieces of the nucleus, which was grooved and divided. But unfortunately, in this case, after removal of all pieces, I got a vitreous loss because of the zonular prolapse, the zonular dialysis, and it's not nice case in my opinion, and I was stressed all the time during this case. Actually, it was ended in peace, and I implanted the IOL, and the patient could see, but with coronary edema for a long time postoperatively, and the patient was not happy for a time. So the message and lessons I have learned from the time I spent with these techniques, that the manual small incision cataract surgery in very dense brown and cataract negra could be a better solution than phaco, because it will save the cornea in cases who are very old or with bad endothelium, keeping the procedure sutureless as well as covered wound to protect against infection, especially in the immunocompromised patients. With the skilled surgeons, it will take a shorter time, really. It happened, and cheaper cost as well as safer trip. Other perspectives, you will have less astigmatism postoperatively. Even in soft cases, you can do it. In subluxated also, yeah, and you can implant CTR and congenital cataract as well. Could be combined surgery, combined surgery cataract and glaucoma. You can use premium lens. Why not? You can fashion a good rhexis, regular and wide rhexis, and you can put at the end premium lens if this patient is candidate for it by the other investigations you will have. After mastering, it takes no time, average 6 minutes. I'm not talking about the genius and pioneers who are doing it less than 6 minutes, but the average time is 6 minutes. This is my idea about the manual small incision cataract surgery. It's a very good alternative for the extracapsular and for the phaco and the hard cataracts. And thank you for your attention.